Hey everybody, this is Brian Atkins. I'm one of the emergency medicine faculty members. I've kind of taken as my role to try to make sure you guys have a good experience if I can. And in doing that, I try to give you a little orientation at the beginning of the month. We used to meet live, but it wasn't feasible for everybody's schedule because people would have to come in early morning after working late and then have to come back and work that night in the department. The internal medicine residents don't switch until the 4th. And bottom line, it became very difficult and onerous for you guys to have to come in on your potentially a day off or come in early for work. So I thought it'd be best if we did a online orientation process. Um, First of all, I want to welcome you here. I think you'll have a great time this month. I think it's a good opportunity to see things that you'll not see on your typical practice. We're a jack of all trades, master of none. And we get the opportunity to take care of a lot of different kinds of patients. I think you'll find it an entertaining month. I think you'll actually have an opportunity to come away with a lot of good stories too. And hopefully you can see some things depending on your specialty that will help you strengthen your clinical practice. It's also a good idea to understand other people's patient care settings, and I think it'll make you a better all-around physician by understanding best what can be accomplished in the ER. If nothing else, for when your family members call you up because you're a doctor and bug you and ask you, should I take such and such to the hospital, you can kind of give them an idea. Well, typically they did this and that whenever you went to the hospital. So as the month goes on, if you guys need anything's obstructing your ability to take care of patients or you're learning, please feel free to contact me and I'll try to get you in the right direction. If you have questions about your schedule, that'll be handled by the chief resident. The interesting thing about working in the emergency department is you can be a master overall clinician, but you can really struggle in the work environment if you don't understand the setting, the system, and the wide variety of nonsense that's going on around you and how to navigate several bizarre processes. So I think that's the most important thing that we can go over this today is how best to make your month most efficient and less frustrating. Most important thing before you come in for your rotation would be to call IT at 323-8586 and call and get yourself set up for the ER tracking board. And I'll show you generally what that ER tracking board is. By never having been a resident, only minimally with Sunrise Clinical Manager or any sort of EMR, I didn't face the difficulty you guys will face with regards to having to get a different screen and things like that. So with your ER tracking board, you should have something like this that gives you a look at the entire emergency department. Now this is not real patients, and this is a test environment, so these are not real patient encounters, so we'll be able to post this up as a YouTube video. The previous video I made, we couldn't cut out the patient's name, so we weren't able to send it out as an online link. So when you get set up through IT for the ER tracking census, you'll have to call ahead of time because they don't really take it to too much of a priority to get it done. You'll be able to see this board, basically just be able to see from, for example, like 1 through 77, which is what our beds run. And that's what you can see with this particular screen we can see right now. Forgive me for being inefficient and getting it started up. I've been up all night with a fussy infant, 6-7-week-old child, my first, and she is laying over here making noises and trying to distract me while I do this. So after you get set up with IT, you'll be able to see this tracking board is where it's showing right now. The beds are split up through the department in a way that you'll pick up quickly as you come on board. 1 through 9 we call our swing beds. These are beds that we use for children or adults, and they're over near triage. The beds 10 through 21 are used for children. You can see those here. Beds 31A, B, 32, 32A, B, and 33A and B are the fast track beds or the chair beds. Those actually are a series of 6 recliners that are set up inside of an open room, somewhat of an internal waiting room, and they're set up to where you can take the patients from those areas over to bed 30 if you need to examine them in a bed. Most of the time, the chair stretcher or chair beds are used for people. They should be used for people with tooth pain, ankle pain, wrist pain, some sort of minor ambulatory illness that does not require great exposure or being supine in a bed. But you'll find out that usually it doesn't work out that smoothly. It's usually more complicated patients than that. 34 through 37 here are other beds that have been considered to be fast track beds in the past, but it hasn't really worked out like that. We commonly have borders up to even ICU borders in those beds many times. If you go to the back area from 41 to 55 is acute care. Acute care is set up to be for your moderate acuity patient, your gallbladder attack, your appendicitis, your chest pain without severe EKG changes or hemodynamic instability, a COPD exacerbation. Basically, people who may require workup and be there for a while, who are moderately ill but not unstable. Your beds 60 through 67 are the beds that line up in front of our doctor's charting area. Those are critical care beds. Sometimes those are just as simple as chest pains and minor shortness of breaths as well, but they can be filled pretty regularly with ICU type patients. Finally, the 70 through 77 are your trauma beds. Main thing to do when you look up here as you go up on your first day is, first thing you'll do is you'll want to figure out if there's a new patient to be seen, and you'll look for a pink flashing light. See here next to 38.100, Miss Tammy Test has a pink flashing light in the resident slot. So you would click on this, sign yourself up for the name. We'll put my name in here next to it. Here's where the attending would sign up. A lot of times attendings will like to sign themselves up. I personally like to, because it helps me keep track of who I have and haven't seen yet. Now, you can tell, just as the resident sign up right here, you can go off to the side and see what the name of the patient that's being seen is. For example, if you wanted to get a hold of who is taking care of this patient, this SCM61 patient, is an 11-year-old with abdominal pain, you can see that the resident listed taking care of them. I'm sorry, I'm having a little trouble here with my sunrise. It's frozen up on me. I know you guys are surprised that during the process of a bootleg ghetto demonstration that we would also have a technical difficulty. Hold on, there we go. It seems to have broken loose now. I know you guys are just absolutely shocked that we would have any sort of technical difficulties with SCM during the process of demonstration. So here you can see that the resident is listed as Diego. Who Diego rotated with us in the past. I'm not sure how they determined that he was the resident, seeing children in pediatrics. But he's a great guy, and we're happy to have him on the orientation video. You can scroll over here and see that the attending is listed as Elizabeth Davis. The nurse is listed as Misty Allen. The tech, Sarah Arnold. Now, out here next to this, you can see that there are labs done on this patient. 6 of them, and 6 out of 6 are done. You can check the status of respiratory therapy orders here. You can see what type of bed is available for the patient. Looks like that patient is probably being admitted to peds. And then you can put commentary in here. That green typically means the patient has admission orders put in. That's where it says peds. And then in this commentary, you can put something in here if it helps enhance communication, like waiting on CT scan. Now that you know who is taking care of the patient and how to sign up for one, let's go down back to this Tammy Test that we signed up for, and let's see what's going on with her. So before we go and see the patient in real life, the best thing to do is to read the triage note, which is under documents. This way you'll get an idea of what the nurse has written down triage. It gives you a better idea of what's going on with the patient. Typically you go to documents, a triage note would be available on this one. It does not have one listed. Let's see if there's one here on this patient, SCM patient 61. That one doesn't have one either. I was told by IT that this would be the best method to do this. Okay, we have a triage note here from a December visit. You click on this. This is moving exceptionally slow, even for SCM. This is painful. You can see right here the patient's triage note. Now this was a triage note actually from a previous visit, but this is the way that the test environment is lined out. It has your triage time, the chief complaint, whether they walked or came in by ambulance, generally the health history of the patient, the acuity level. Typically on down through here we give you a brief synopsis of the patient's presenting complaint. Commonly they would say patient presents with abdominal pain, nausea, vomiting, something like that. Why it's very important to read these triage notes is not only does it give you a summary and a heads up before you go in the room, and patients, as they go through the process of being checked in, it's an ER, it's a little different than a clinic because the triage nurse asks them what's wrong, and then the resident asks them what's wrong, and the attending asks them what's wrong, and sometimes the medical students mixed in there, and they get pretty frustrated. So it's nice to have a background information, at least walk in and say, you know, the nurse said you've been having abdominal pain for a few days. Tell me about it. And I think most of the time that enhances the communication. The other reason why is sometimes you'll literally see and treat someone for something that seems like simple and straightforward, like an ankle sprain, and you'll go back and look at the triage note for something like their allergies or their health history while you're dictating the note, and the nurse has written, patient had severe crushing substernal chest pain, felt like his heart attack, stepped off, almost passed out, stepped off the curb, and twisted his ankle. So that's the last thing that we want to slip through the cracks. So it usually gives the vital signs, it gives the presenting complaint, at least they told the nurse. Now, the other things that are important here, flow sheets. Now, this test environment with patient confidentiality names, which not only runs slow, doesn't have everything set up perfectly like I would want it to, but it can give us a little bit of opportunity for a demonstration. Here we have point of care. Under point of care, that's where you'll see the urine dips. We can actually run urine dipsticks, basically a computerized version of the old strips that they use in the clinic to hold it next to the bottle for assessment. We get urine pregnancy tests, we can do strep screens, and we can do finger stick blood glucose. We used to be able to do breathalyzer alcohol screens, but we can't do that anymore. Our machine broke for that. If you want other information here, a lot of it is listed in. Vital signs is listed in here commonly. And if you got orthostatic vital signs or so, you can click under here to get that. If you'd like to get the vital sign tracking for the entire time that they're in their visit, you go into CDV. Then you always get an opportunity to watch the slow computer retrieve data. Now this one it's blank, but typically on most visits it would have the triage vital signs followed by the vital signs as they're tracked throughout the time of the department. It also will give you the patient's pain rating and etc. as the nurse has documented. Also you get an opportunity to see if they've written down based upon consultation visits and based on any of your time in and out or whether the family was here, they keep their documentation there. We may as well go through the rest of the stuff up here. You can click up here and see the orders that have been done. I'm sure you guys are familiar somewhat with that. You can click here for results. You guys are probably familiar with that. Documents, I'm sure you're familiar with. Blow sheets we've looked at. Patient info is something that can be helpful. It gives the patient's address, phone contacts. Here's one that's very helpful. Visit history gives you an idea of how often they've been to the emergency department. Also helps you, patients who are not sure who their doctor is at UK, helps you identify who they've been seeing and how recently they've been seeing. It's got the insurance here, which um, some people would tell you that that doesn't make any difference to them. But if you're going to write a prescription for a patient or assess their ability for follow-up for a complicated visit, you bet your boots the insurance is very helpful. And if they've got it documented on here, like you see here, this one says they have an insurance plan. That makes me feel much better about the fact that they'll be able to comply with my outpatient treatment. The other thing that is nice to have here is address, phone contacts. This is if something gets slipped between the cracks that you'd like to contact the patient about. Over here is images. I'm not sure if they'll have any loaded up on this test environment, but here you would have a list of the EKGs. You could click on it. You can compare the EKG done that day to EKGs done at UK in the past. Really, it's extremely helpful. And here's the PAC system. So anything loaded up in the PAC system, you can actually click here and pull up that image to look at. So when to put in orders. So in the process of things, we've already determined that we're going to sign up for TAMI test. We clicked our name next to it. Also, as soon as you click your name next to it, I'd like for you to go over here and click treatment in progress. That helps the bean counters know that the patient is being in the process of beginning to be evaluated by a physician. It's important from an administrative perspective as throughput, time in the department, time in beds, time to discharge or admission are all important things that are followed closely by administration. So it helps us if you sign up the person, you click treatment in progress. So you do that, we agree, we pull up the triage note under documents, get an idea of what the patient's there for, and then go see the patient. After you see the patient, what's next? Well, depending on your level of experience and confidence of what's going on with the patient, you can either put in orders, and I would encourage you, especially if it's not a controversial or outside of the box treatment, or it's not a substantial test that require significant time, cost, or radiation that you're not sure of, that you go ahead usually and begin to treat the patient, at least if it's not really accessible to speak to the attending. Probably the first couple of days of your rotation, it'd be wise to go ahead and find the attending and check out the patient just so you get a general idea of what they're looking for in the flow. But if you go and see somebody who's in a lot of pain, there's no reason to withhold that. If you see somebody whose ankle is really swollen and you know they need x-rays, there's no reason to withhold that. If you see somebody who's having a GI bleed and you know they need basic blood work and hematocrit, there's no reason to hold on that. Go ahead and establish the IV. It was something with regards to whether or not you're not sure if you need to CAT scan someone, whether or not you're not sure someone needs blood work for an assessment, might time up for a couple of hours, then just go check it out to the attending first. Now, speaking of going to check out to the attending, that'll take a little bit of time to get used to. During the hours from 3 a.m. until 11 a.m., there's only one attending in the department, so it's very simple on who you check out to. However, starting at 11 a.m., when a second attending arrives, first the attending that's there 24 hours a day, that one usually sets in the charting area next to the telemetry monitors in the doctor's charting area facing bed 63. That patient will take everything when they're there alone. Obviously, whenever the other doctor arrives, they'll sit in the corner just behind that doctor, that attending, and that person will take odd beds. So you would check out the even beds to the front attending and the odd beds to the attending just behind them. We just split it evens and odds so everyone got similar acuity. Now, as far as determining what's even and odd, for example, these beds here, 38.100 through 38.105, these are actually hallway beds. We go by the lowest or by the last number. So 38.100 would go to the even attending, 38.103 and 105 would go to the odd attending. So after you've seen the patient and you want to put in orders, you guys I'm sure are familiar with how to put in orders in SCM, but there is some things that we have done to enhance the ordering experience and optimize it time. So instead of just typing in CVC in every little lab you want, we have EM abdominal pain order sets. or no, it's just abdominal pain, forgive me, EM order sets. So these just go through common ER presentations, and what you have here is a pretty quick way to pull things up. Now, just because let's click chest pain, patient has chest pain. I apologize for how slow this is going. You can see here that a bunch of stuff for chest pain is already up here where you can just go through and click. Now, your patient may not be incumbent, there may not be no reason to check PT and PTT. This person may not even be a person you want to check a troponin, but it's easy to click and unclick. You can click aspirin here. If the person needs morphine, you can click that here. If they're sick of their stomach, you got some Zofran here available. You can do your IVO2 cardiac monitoring. If you think the person needs a 2-view chest, you can click that here. All the basic things that you would want to get for a chest pain are available here. Just because it's on this list, just because you see it on this list doesn't mean that the patient has to have a PT and PTT. That's set up for the nurses whenever they put in orders on like a cath lab patient who the coags are significant importance on. So you can go over here and you click OK. And we also have ones for example, abdominal pain. This should make it much faster than putting in each order separately. So we see we got CMP, CVC, and lipase pulled up here. That doesn't have to, you don't need that on every person. But if you thought the person needed an IV, you thought they needed some Pepsid, thought they needed some Zofran, here you go. You click it all, you got all of it once. Keep in mind, every woman with every woman with abdominal pain in the emergency department is pregnant until proven otherwise, pretty much from about age 10 to about retirement age. So we're all really like paranoid about that. So click here on pregnancy test. And actually, we'll probably want to check a urine most of the time as well, unless it's just frankly upper abdominal pain. It's just a rule of the road. So I think you see how to use the order sets. Those are going to be extremely helpful on your patients. Okay, so next one would be if you don't have something that fits in. So you got somebody with a weird complaint, you're not sure how that fits in. Up here we've just got common lab orders, common radiology orders, and common ultrasound orders. So say you need a sed rate and CRP, but you didn't want to type them all in, you can click on here and it's listed. You can see most things that you would want reasonably to order. And keep in mind on emergency patients, we're not really ordering a lot of tests that aren't going to come back immediately. So a lot of things like that aren't necessarily on here, but the things that you might order to get back in a reasonable amount of time are here. Your common radiology orders are here. So if you have somebody that they fell and they hurt their elbow and their back and their knee, and you didn't want to enter all those in at once, here you got elbow. Here you've got their knee, and then you can click over here on the spine films as well. Now the common ultrasound orders are helpful because they help with some of the stuff. It seems like no matter how I order an ultrasound, the ultrasound tech calls and says I ordered it the wrong way. Here we've got the pregnant pelvic ultrasound, or non-pelvic pregnant ultrasound. This is the person you're looking for an ovarian cyst or torsion. The ultrasound admin is typically the trauma ultrasound for free intraperitoneal fluid, which we usually do on our own, so it's not of most importance. Pelvic transvaginal, that's usually in someone that, depending on pregnant or non-pregnant, that you're trying to look at, especially in the early stages of pregnancy when the beta quantitative HCG is very low. It will give you a closer look. Here's a Riper quadrant for gallbladder. You got the scrotum ultrasound, everybody's favorite. Now, for DVT ultrasounds, these are broken up as well. These for venous duplex, the lower extremity, unilateral or bilateral. These are actually done in the vascular lab. These are the ones that are done by radiology. The difference is the vascular lab's only in basically banker's hours, Monday through Friday, 8 to 5. They actually ultrasound the entire leg, all the way down, including the calf, to look for DVTs. If you get the DVT ultrasound done after 5, you should order it here or on weekends because it's done by the radiology department. They actually only ultrasound the popliteal space. So that's important to know not only which way to order it, You order the venous duplex up here through vascular lab during business hours. After hours, you order it through radiology. And radiology, keep in mind, only goes down to the popliteal space. And that's because a lot of people feel like that anticoagulation of calf DVTs is not necessary. But that's a learning point or a scientific point that's not necessarily brought into this. But you still should know the limitations of the test you're performing. Okay, we talked about that we don't really order labs that don't come back that day. Now, what patients to see? That's a great question, and it's really person dependent. Now, the pediatric residents used to see adults and peds when they're on the rotation, but now they're pretty much over here in this area. That area is very busy with pediatric patients. So they get a great pediatric experience typically, and so obviously you pediatric residents will be over here, and you won't need to learn the rules of the road for the adult patients so much. As far as all other residents rotating in the emergency department, you're welcome to see patients in any area of the emergency department. What I would say, though, is that depending on your level of experience and depending on your familiarity with things like trauma or critical care, you may want to modify what you sign up for. If you're an intern in the first few months, you may find it overwhelming to see a very sick patient. What I can tell you is definitely fair game to see for all of you guys is pediatrics. If there's a critically ill child, somebody will be hovering over it before it even hits there, before it even comes in the door, and so you won't have to worry about accidentally doing that. Everyone is welcome to see the 30s beds, as well as the 41 through 55. Where it gets tricky is critical care and trauma. So the 60s beds, those can be as simple as a routine chest pain or COPD exacerbation, or palpitation, something like that, depending on our bed availability. And so obviously that person would be able to be seen by pretty much anyone. If you're an intern and you're not used to taking care of sick medical patients, you should take some pause before you sign up there, or at least read the triage note or walk by and look at the patient and make sure it doesn't look like someone's tremendously unstable. Now, as part of your educational experience, I'd love for you to see those patients anyway, but you may want to figure out what you're biting off before you go in there, and if it looks like something that is a very difficult patient, you may want to go ahead and run it by the attending or one of the upper level ER residents in order to have someone on board with you to assist you in caring for that patient. So I really want you guys to see sick people. Those are the most fun ones to see. But if you are uncomfortable with the level of acuity, then certainly you would want to ask for assistance before you signed up for it. And depending on the person and their specialty, that doesn't necessarily mean that you wouldn't be available to do that as an intern. It just really depends on how much experience you have and your comfort level. These trauma bays, typically the moderate to high acuity trauma patients are seen by the emergency medicine residents, and one exception to that is the anesthesiology residents have quite a bit of experience and actually look to gain more experience with acute trauma resuscitation, so they should feel free to be available. Now, if they're going to sign up and see a sick trauma patient, you may just want to let the upper level ER residents and attending know, just so that everyone knows that it's assigned. But I think that's a reasonable expectation for them to be involved on those kind of patients if they desire. Now, a good deal of the patients over here actually don't end up being critically ill trauma patients, and that's where the reading the triage note, cruising by the room, and taking a peek in can be helpful. A lot of these patients come over here with finger amputations, traumatic finger amputations, moderate extremity fractures, old people who actually just fall and have hip fractures, etc. Not every one of the patients that come through here are people who have admitted to blue surgery. In fact, most of the people who come into this area are discharged from the emergency department or admitted for surgical treatment of an extremity trauma that is not a critically ill patient. So I'm not telling you not to see patients 60s, 70s. I want you guys to have a fantastic experience, see everything that you can see. But bottom line is you should be aware that these areas may have patients that are complicated and that you may need assistance with if your comfort level is not there. But that's part of the learning process. So if it's something that you're not comfortable with, then just grab somebody who is comfortable with it and see if they can help you see it. As you guys watching this video may or may not know, the people we have rotating through the emergency department are from a whole lot of different services. We have pediatrics, triple board, which is the peds and child side combo. Med peds, we have internal medicine as second years. We have family medicine as interns. We have orthopedics as interns, ENT as interns. We have anesthesiology as second years, and I'm sure that I'm forgetting some of the groups that we have rotate through with us. As you might imagine, the sick medical patients are exactly what the PGY2 medicine and anesthesia residents are specifically looking for on their rotations. And I would encourage all of you guys to get out of your comfort zone and see things that you're not familiar with. I think one of the best things about the rotation is the surgical guys get familiar with basic medical stuff that they haven't seen maybe since medical school, and the medical guys get a comfort zone with minor orthopedics, lacerations, abscesses, and some components of trauma that they may have not seen since medical school. All right. As far as how many patients to see at a time, that really also depends on your comfort level. I think as a general rule, whenever I rotated as emergency medicine resident, I always felt like that if I wasn't a little bit stressed, I wasn't pushing myself to do everything that I could. But at the same time, if you get yourself overly stressed, then what you'll do is you'll end up with a whole rock garden of patients, and you'll have distractions from each end on multiple different patients that will make it less efficient to take care of any one patient. I would think that your speed depends on the acuity of the patient you're taking care of, the severity and time-consuming procedures that may be associated with some patients. Sometimes you can be busier with 2 patients than you can 8 patients, depending on what type of patients those are. What we'd like for you to do is, we know all you guys are good people and smart people, hardworking people. You wouldn't have made it as far as you can. Just see as many, pitch in and see as your help is very important to our ability to see the patients in a timely fashion. So just pitch in, work as hard as you can to help take care of patients, but don't see so many patients that number one, that sick patients don't get appropriate time from you because you're trying to juggle too many things. Don't take so many patients that your lower acuity patients can't get in and out of the department because you're so tied up with other procedures and factors. Don't see so many patients that you're not able to take time and document during your shift, because documentation of the patient's encounter is so important on multiple levels, both the patients and the providers, from medical continuity and legal reasons. So I guess there's no real answer for that. See as many as you can without making it tremendously hard on yourself or your patients. Now, the paging system, I'm not sure how you guys are familiar with the beep system, but I can't pull it up obviously here on this desktop, but the beep system is available, which gives you, if you type in beep under the prod system, it will give you the pagers for the on-call people. You can also, if you can't find through the beep system, you can commonly call UKMDs 257-5522, and they can also tell you who's on call. Many of the services have service pagers that will be one specific pager that pass from person to person that gives you a number that you call generically. Most of the ER people are familiar with those. For example, the Blue Surgery Junior Resident always carries 330-0912. The orthopedic resident carries 3306946 and on. Internal medicine hospitalist attending carries 3306951. You'll get familiar with those as time goes through. If you can't find them in the computer, just ask somebody and they can usually tell you. Now, if you're going to ask someone, speaking of calling someone, if you're going to ask someone to see a patient, you put in, at the time that you call the patient, you put in a consult. Whenever you call, discuss that patient with another physician. This is another thing that's onerous to do, just like clicking on treatment in progress, but is extremely important to administration. So if you don't do it, someone will invariably complain at you that you've not been doing that. So to put in the consult order, you would go up here to the order entry. You type in ER consult request. For example, if you call cardiology, you would click on ER consult request cardiology, you double click there, and it would come up. And after you do that, it would, well, I'll just go ahead and do it so you guys can see. Click here. And it comes up here that cardiology is seeing the patient. That helps keep track of who's seeing the patient and what time that you involved them in the care, so that it can just assist everybody to know what's going on. Next thing would be how to do a discharge. So we figured out that Tammy test was okay, and we're going to let her go home. So here you would put in discharge. You would put the follow-up that the patient should have if they're on one of these lists. If you're just doing a generic discharge, you would put in the working diagnosis here, the prescriptions you gave them. You would want to specifically document any opiate prescriptions that you wrote for the patient instructions of things to come back for, how many days until their follow-up, and then who to follow up with. A lot of times it's just as simple as your own doctor. Sometimes if you can't find the list, you'll put all UK clinics and say you want them to follow up with, let's just randomly say gastroenterology. You would put here, and the nurse would be able to put that in. Now, sorry if there's some racket in the background. My poor child is being fussy again. So here, on this part, if you want to do follow-up, one of the big ones is with orthopedics, because the way that ortho is able to track what patients came out of our department to follow up with them is through this. It sends an automatic email to their clinic and lets them know what the patient has wrong with them so they can schedule it. Our orthopedic department has to see patients who are in. You just enter the discharge here. They have to see patients who are like all the other services here that are that could not get care due to lack of insurance in other places. And the way to filter out which patients are actually established with UK through our emergency department is commonly through this system. So I think you kind of see how we do the discharge there. Forgive me, there's a little break in the action there. My child got even more and more fussy. So another thing actually that is important on your discharge, if you send someone for an acute hand surgical condition like a hand fracture or a severe infection that's going to be following up with a hand surgery clinic, it is important to note when you do your discharge whether they're going to orthopedics or whether they're going to the plastic hand surgery clinic. The reason why is that plastics and orthopedics split hand call, and because there are more hand attendings for plastic surgery, they'll take call with the orthopedic residents. So it can sometimes get confusing. You want to make sure in beep system that the attending on call it actually matches the service you discharge them to. So plastics is on call even if one of the orthopedic residents is helping us take care of that patient with backup. If there's OR time with the plastics attending, they'll actually the patient will still follow up in the plastic surgery clinic whenever you do the discharge. Now, the next thing to talk about is how you can be reached in the department and how you can reach other people. There are Cisco phones, which are the cordless phones that you'll see a lot of the ER residents carrying around. When you're on shift, if those haven't all been hogged up by the ER residents, you want to grab one of those, and on the marker board in the department, the best way for people to reach you, because it is a huge department. It's the size of a football field, and you're going to put in calls to consultants, you're going to put in calls to family and people to get a hold of you, and social services and everything, and you're going to have to stand there in the charting area and wait for that call to be returned if you don't get one of those cordless phones. So that we can get a hold of you and so that you can have more flexibility and freedom in the department, you should put your name and what the name and the number for the phone that you're carrying with you, and just slide it in your pocket and take it with you, make you much more efficient, and save you a lot of frustration. Now, if you want to reach someone in the department, if you have a patient you're concerned about, other than just sending the nurse to find the attending, which is actually not a bad strategy a lot of the time, is you can reach the attending that sits in the front area facing 63 that covers all the beds in the middle of the night and the even beds during the double coverage hours. You can reach them at 323 UKED or 8533. So 3 UKED. If you want to reach the pediatric attending, and I don't think I told you this earlier, but from 2 to midnight, all the children in the pediatric side are seen by the attending who is specifically covering the pediatrics area. You can contact them at 3 PEDS. Now, if you want to reach the attending that's behind them, 32509 is the number for that. Now, another way of getting a hold of people in the emergency department is through the Vocera, which are the portable walkie-talkies that hang around everyone's neck. They also use them up in the operating room, so you'll see some of the anesthesia attendings will have those on as well, because they take emergent airway call and can be reached that way. It is basically a voice recognition walkie-talkie. Now, you won't have one on your rotation. We used to have it set up for rotating residents, but unfortunately they were turning up lost and they couldn't continue to get them. And so, the good news is that you can reach other people, and it makes it very easy about getting your nurse, because you'll find that you can never find anyone in that department that's too large. So let's say here this patient in SCM 61, and you wanted to reach their nurse, which would be you see that patient has Natalie Arrowwood as a nurse. So you take the first and last name of the patient. You would dial on the phone 3970 or 39700, and you would say Natalie Arrowwood, like a robot, and it should pick it up and it would take it to Natalie Arrowwood's Vocera that she's carrying. Or, for example, if you wanted to reach the attending taking care of the patient, and you see Craig Carter signed up, you would just dial 39700 and say Craig Carter. Now, the Vocera can also be used to reach other people in the department who are very helpful to us. One of those is the ED Supply Tech, which is a tech that's hired to stay in the emergency department, and they know where everything's at. They can get you whatever supplies you need, from the OR, endoscopy, just around the department. If you need to sew up a laceration, you need to do an incision and drainage, whatever you need, you call Vocera 39700 and say ED Supply Tech. It'll go to the ED Supply Tech, and you can get whatever stuff that you need. They can help you find it. Now, another person you can reach on Vocera that can be very helpful also would be the ED pharmacist. And ED pharmacists are typically in the department from I'd say about 10 or 11 in the morning until about 10 at night. And you can say, call ED pharmacist, and you'll get the pharmacist, and they can help you out with a whole bunch of stuff. Now, off the topic of this area and on to beginning and end of shift, when you come on the department, you'll probably be in the mornings. You'll probably be coming on with no rotating residents, but certainly in the evening, if you're coming on to shift or if you've been on the day shift and you're leaving, you'll want to check out your patients to the next rotating resident who's coming on. Um, that way, there's continuity. So you want to go through your list of patients with the other rotating residents, and this can be check out. It doesn't have to be if you're internal medicine. It doesn't have to be another internal medicine resident. You can check them out to the family resident, anesthesiology, orthopedics, ENT. Makes no difference, but you'll whatever rotating residents coming on that evening, you want to make them aware of all their patients. Now, if you're leaving first thing in the morning and there are no rotating residents coming on at 7 a.m., then you would check out your patients to the ER residents. If you have a multitude of patients, I would suggest, since there's no defined person to take your checkouts, that you would check them out to the, you would divvy them out among the ER residents so that one person doesn't get completely hammered. If there's just one or two, you probably just find one person. Now, it's important whenever, and we'll talk more about documentation in a little bit, but it's important whenever you do your notes and document your notes that you, when you receive a patient and check out, that you go back and put an update based upon the results or whatever's pending on a patient. So you might just put in, patient was turned over to me pending CT scan of the abdomen. CT scan revealed no appendicitis. Patient was improved, able to tolerate an oral fluid challenge, and was able to be discharged home. We'll follow up with their doctor tomorrow. You just want to put information in that that took place after you left, or alternatively, the patient troponin came back elevated, cardiology was consulted, the patient was given aspirin. The next thing on the list is transfers, and that can be extremely difficult to navigate with regard to that. We have a heavy volume of transfers that come into our emergency department. All transferred patients, even if they're, most of which are accepted by specialists of some sort, they're all seen in the emergency department by us for a medical screening exam. That's a hospital rule and policy. So every single person that comes to the emergency department has to be seen by us. The only exception would be a patient, say a patient was a critically ill transfer and the attending physician who was accepting was at bedside and ready to see them as soon as they arrived. And that is a very specific circumstance. It does not occur very often at all. In general, we should be seeing those patients and assisting in the management of any transfer patient to do medical screening and try to assist in their care. It also is very helpful because some patients are inappropriately transferred in for the wrong reasons or at the wrong time of physician, and we can often assist with the accepting service with getting them, the patient, what they need. The process, though, of getting a transfer patient where they need to get is can be complicated. First thing you want to do, besides the typical, which is sign up for the patient, click treatment in progress, assess the triage note, go ensure the patient is stable. First thing you want to do after you evaluate the patient, before or after you evaluate the patient, is look at the patient's chart for the information from the other hospital. You want to find out what tests were done there, what diagnosis and suspicions they have. Even if they're way off base, the information that has already been gathered on that patient can provide invaluable resources for us, even if they've gone about it the entire wrong way. And that's not to criticize, because most patients, people who are transferred in, have had a good, honest attempt at evaluation, but they just didn't have the resources to deal with it. But regardless of whether or not the diagnosis is correct, we're responsible for the information in that chart. So the first thing we do is gather that information, determine what was done in there, including labs, x-rays, CTs, and other diagnostic tests. A very important part of that is to look at the transfer note and see who the patient was sent to see. And typically there is a transfer note which tells who the accepting physician is. That would be the person that was reached by UKMD's for the patient to be transferred and see. Um, does occur on occasion that a patient will come in what we think needs to be seen by a certain type of doctor, or the person will get admitted to, um, say, general medicine, but there was a call placed specifically to cardiology or pulmonary, and they had a specific interest in that patient and a reason why they took that patient transfer. So it's important to make sure we know who the accepting physician is. Now, typically, once the patient is proven to be stable, and we can look the person over and make sure that they're generally on the right track with their evaluation, we call the accepting service. So if you got somebody who's transferred down for stroke, they've already had a CT scan that shows no bleed, and that patient does not require intubation or emergent critical care, it should be fairly obvious that if you think the person's had a stroke, you go ahead and directly call neurology. If you see a person is transferred down for acute renal failure, and it seems to be relatively straightforward that the person's in acute renal failure and that there is no indications for emergent critical care or no surgical pathology that got missed, it should be pretty clear you go ahead and call the internal medicine doctor on call. Or on and on. If the person's there for chest pain and you don't think they have a dissection, you think the acute coronary syndromes need to be excluded, you call the cardiology fellow. A fracture, orthopedics, on and on. But it is important for patient care purposes and also for general just working together and being a good colleague. You want to determine what was done at the other hospital, get an idea if there are things that need to be further explored or worked up, and just generally get familiar with the patient and make sure they're getting what they need. For example, if you have a patient that's transferred down for a fracture and they're to see orthopedics, ortho would like to have new films done at our hospital. And so you want to go ahead and order those films and get those films done. And in the absence of a neurovascular compartment or surgical emergency, it's common courtesy, we usually get the films back before we call the orthopedic resident. If you have a patient that was transferred down for what they thought was a medical reason and you identify a surgical pathology, then you obviously want to continue to work excluding that surgical pathology before you would call them. For example, if you had a person with GI bleed, a stable GI bleed, that you went and examined the patient, you thought they'd actually perforated an ulcer, you would not call the gastroenterologist immediately until you excluded that surgical condition. Or if you had somebody transferred down for suspected cholecystitis, but you notice the person's in acute renal failure with hyperkalemia and requires emergent hyperkalemia measures or dialysis, you want to go ahead and make sure that's appropriately being treated and evaluated during the time that you're calling the surgeon about the cholecystitis. The one exception to all this is the ENT. ENT, through their chairman, has worked out with our chairman that any patient that their attendings discuss that gets transferred down to be seen by their service, they don't want us to do any further workup at that time. Now, obviously, you still treat the patient, that that person has pain, if that person needs emergent stabilization, you do those things. But ENT does not want any time spent in ordering any further tests or any things that could delay it. They feel like it's best if that person is immediately seen by their service, and we certainly appreciate that hard-working attitude. So we go ahead and call ENT as soon as we see that the patient was an ENT transfer. We go ahead and call them if there are other coinciding medical issues or problems that are stable that can be worked up. The ENT resident, you can work it out together when they come in. Don't feel the need that if somebody's come in for exclusion of a neck mass to order a CT scan, ENT would like to see the patient and discuss it with you, and they'll help you go from there, determine what needs to be done. Now, pediatric transfers, most pediatric transfers, they've just called the someone in the emergency department and transferred those people in. We don't turn down any pediatrics, can't turn them down. Invariably, a good deal of the transfers that come in for pediatrics aren't patients that eventually have to be admitted to the hospital. A lot of them are. I don't want to say, I can't give you a percentage, but especially a lot of the breathing kids or dehydration kids, they'll get pretty effective treatment at the other hospital, and after they've been called and got an accepting physician and transferred 2.5 hours by ambulance, they'll commonly arrive looking like a rose and look like somebody that doesn't need to stay in the hospital. And so we go evaluate those patients. Just because we walk in the room and they've been transferred to peds, we don't immediately call them. We look the person over and determine if that person can be stabilized and sent home to the emergency department. A decent percentage of them can, a lot can't. The alternative thing you run into is sometimes from a social perspective, the family is under the impression that their child's so sick they've been transferred down multiple hours, and transportation issues, parental concern and fear will not allow them to understand that the patient is stable for discharge. And pediatrics has been a good colleague in that they understand that, and if the patient's family doesn't feel comfortable going home based on our recommendations, they'll commonly come and see the patient and admit them or provide a supporting opinion so that can be arranged. A similar situation occurs with trauma. Some other hospitals are just not comfortable dealing with trauma from all the complicating factors that go along with those patients. And even if those patients are accepted by the trauma surgery team for a traumatic injury, the calls on everything from a drunk person who has no injuries, that was in a bad car wreck, to an old person that falls and has a hip fracture due to syncope, to someone who just breaks the wrist. And the trauma surgery attending your chief resident commonly says, send them on down if it's a traumatic-based injury. Now, obviously, a 75-year-old with atrial fib that syncopizes and breaks their hip, they don't need a trauma surgeon if they don't have other injuries. They need an orthopedic surgeon, and they need a medical doctor or cardiologist to treat their atrial fib and syncope. Just because the trauma surgery team is listed as accepting physician, that commonly they are just a person who's on the other end of the phone that will say yes. And so if it's obvious it can be taken care of, it should be taken care of by other doctors, we do that. Now, if somebody comes in who's intoxicated that has facial fractures from MVC, we would work the patient up with CT scans, x-rays, whatever is necessary, determine if they have emergent facial fractures. If they do, then we can get them set up with the maxillofacial trauma service, or their clinic is an outpatient. But if that person sobers up and has a broken cheekbone, then obviously they don't need to be admitted to the blue surgery service. So that is one of the other caveats of transfers. However, in general, if someone is accepted by a specialist for exclusion of a specific specialty-based emergent diagnosis, then we commonly involve that person in the care of the patient if they've already spoken to their attending about it, unless there is on our examination it is clear that there's an alternative pathology that's causing it, and typically then we'd still give a courtesy call to let them know that that patient was there and get their input, and that is the most important thing to do for continuity purposes and to make sure the patient gets everything they need. Now, transplants of heart transplant patients will commonly be transferred here. For heart and lung transplant patients, you would want to call the nurse coordinator for the heart or lung transplant team immediately upon their arrival, no matter what they're there for. Something's been worked out administratively, even if they're there for a sprained ankle. If they have a lung transplant, you're supposed to call them immediately, or a heart transplant, to let them know they're there. Commonly, they won't do anything or make any different recommendations, but it is important to them to let them know. Now, there is a radiology reading room adjacent to the emergency department with typically staffed until midnight by radiology attendings and residents, and then radiology residents from about midnight till 7 a.m. You can go over and look at films with them or ask them questions if necessary. We try not to bother them unnecessarily because they have obviously a very busy job to do as well, and we don't want to take up their time. But if you do have specific pertinent questions, you can go talk to them. I forgot something that's very important with regards to transfers. The transfer patient commonly arrives with outside labs, as we discussed. I don't feel it necessary to repeat outside labs that you believe are still pertinent. Obvious differences are if you have somebody comes in with chest pain and has real acute coronary syndromes, and it's been 4 hours or 5 hours, and you think a neutropenia would help the cardiologist, then by all means order it. Or if the person's there for a GI bleed and their hematocrit was 35 to the hospital, but it's been 6 hours in time of transfer, then by all means you can repeat the hematocrit and determine if it's dropping, because that's pertinent information. But just because they had a BMP at the other hospital doesn't need another BMP at our hospital. Final thing about transfer patients is they commonly come with X-rays or CT scans. In the era of cost saving, medical cost saving, and particularly radiation exposures, you do not want to have to repeat CAT scan somebody. Commonly, the patients will arrive with a disc that contains the images on it. That disc can be taken to a computer. There is one computer in peds and one over by across from bed 60 in the adult part of the emergency department, one in trauma, that you can upload the CT scans from a disc with. If you give those, you can either do that yourself or you give that disc to a nursing tech in the green scrubs, and they will take it and upload it for you. Alternatively, a lot of times when you go to the patient, if you can't find a disc, and you know by looking at the chart and talking to the patient they had a CAT scan that showed, for example, appendicitis, but you can't find the disc, if you ask the nurse, commonly they'll try to upload it for us as a courtesy when the patient hits the door. Now, when you upload that disc, what occurs is the images go up under the patient's first and last name based on off of the disc. That would make it available on the PACS system and the PACS computers to be searched under the first and last name and look at the images. However, say for example, this patient had an intra-abdominal abscess and a CT scan of the abdomen here, SCM61 I'm pointing at, was found on CT scan. If you go up here to images and go to PACS, that patient's CT scan is not going to show up there. The way you get that CT scan to show up there is you have to enter in an order. It's called the PACS order, P-A-C-S, PACS outside image order. And what it does, it takes those outside images that are under first and last name and puts them with the patient's medical record number. So if you have an outside CT scan of the abdomen, you click here. Now, one caveat as far as entering these in. Say you have a patient that got a CT scan of the thoracic spine, the cervical spine, and the lumbar spine. Then that patient got 3, and actually if they got their head, they got up to 4 CT neuro. So you can't just put in one CT neuro upload order. You have to click here, and you click OK, and you have to come back in and order it and enter it again. So you click here, you have to click another one. So that you get the head and the C-spine, if that makes sense. It doesn't to me, but that's the way that, the system is set up. So the PACS image upload and the outside CT scan uploading is one of the many responsibilities in the emergency department orientation that is painful and tricky, but invariably one of the reasons why I'm making this video is because it's one of the things that slips between the cracks and everybody expects you to know. We talked about the pharmacist. Now, as far as resources in the emergency department with ancillary staff, we have social services during certain hours of the day. The nurses can help tell you when those are. Occasionally, we'll have people on call that we can get a hold of as well. We have ultrasound, x-ray, and CAT scan, obviously 24 hours a day. We have MRI is usually only available till about midnight, up till 3 a.m. on certain days of the week. The reason I say that is because MRI is very difficult to get a hold of and get MRIs done occasionally, and so you want to be aware of that. We don't try not to do a lot of MRIs in the emergency department, but a lot of our patients who are transferred in are very complicated and require those. So for example, you have a patient who has an acute spine-related condition that you think needs to be evaluated by MRI, and it's 11 p.m., you should be on the ball thinking about the fact that you need to go ahead and arrange for that MRI to be done instead of waiting until later in the night when that person may go home and then you have to call in the call-in tech, or if they don't meet criteria for calling in the tech, then it can be very difficult for the on-call MRI tech, and it can also be difficult for us and the radiologist. We have accessibility to dentistry 24 hours a day, both adult and pediatric. We try not to bother them. The only reason we would call them is for a true dental emergency with a perhaps implantation, reimplantation of a completely avulsed tooth, or a severe dental abscess that's going to potentially make the patient septic or affect their airway. We have a chaplain 24 hours a day that can talk to patients and families who are under a great deal of stress or who have suffered loss or bad diagnosis. Now, going back to consultant work a little bit, I want to differentiate a little bit about certain specialty surgical call. There is a call for hand, as we talked about earlier, that's split between plastics and orthopedics, and is under the beep system, under hand. So you wouldn't look under. Somebody got their finger chopped off, and they came in to the emergency department, and you thought they needed a hand surgeon. You would not look under orthopedics. You would not look under plastics. You'd look under hand, under beep, and it would give you the person to contact. Same as if somebody came in with an acute facial fracture with entrapment of their eye. You need to get a hold of a facial surgeon. You would not look under ENT. You would not look under plastics. You would not look under oral surgery. Although those are the three services that split: oral and maxillofacial surgery, the MD-DMD service, plastic surgery, and ENT all split that facial trauma call. What you would look under is in the beep system, just as there is a call system for hand, you would look under maxillofacial trauma. Now, that's not oral and maxillofacial surgery. That's one of the three services. It's listed under maxillofacial trauma. And finally, there is a spine call. So if someone breaks their spine and you need to consult a surgeon, don't assume that you need to call a neurosurgeon. Don't assume you need to call an orthopedist. You look under the beep system under spine. And under spine, it gives you the person who's on call and what service is on call. Now, if you have a general surgical emergency, there are two main sources of people who can assist. Blue Surgery is the trauma surgery service, and they take most undifferentiated acute general surgical emergencies as well. So in addition to admitting trauma patients to the hospital, they also would see acute appendicitis, acute cholecystitis, acute bowel obstructions, etc. Now, the patients that they would not see are typically covered by ESS, or Emergency Surgical Services. Emergency Surgical Services, the ESS resident, carries the pager 330-0001. And what they cover is for vascular surgical emergencies. For example, if you had a cold or blue foot that need to be reperfused, you would call them. They also cover for the gold surgery service, which is the cancer surgery service. Now, if the person was an undifferentiated person with a new bowel obstruction that they thought potentially could be cancer, you would still call blue surgery, but you would call gold surgery if that patient had been established and already been receiving care through the gold surgery service. Same with the green surgery service. The green surgery service covers a lot of gastrointestinal outpatient surgeries, colectomies, and colorectal emergencies. So if you have a patient who has an acute perforated diverticulitis, you would call blue. However, if that patient had already had a partial elective colectomy for diverticular disease and established the green surgery service, you would call ESS and they would cover for that. Now, obviously, during the days, you might imagine green, vascular, they have their own teams, and gold have their own teams, but ESS is the after-hours coverage, which is when we're making most of our calls. ESS also covers pediatric surgery, so if you have a child with a surgical emergency, you call ESS. So that's kind of how they're divvied up. If you have questions about it when the time comes, just ask one of the ER residents. They get to be experts at figuring out who takes what. Finally, we'll get down to a couple of issues of documentation. As you guys might be aware, House Bill 1 was passed a couple of years ago, which mandates that any patient who gets an opiate prescription from the emergency department has a CASPR, which is a Kentucky registry that keeps up with pain medication filled prescriptions. You have to review that sheet. Now, every person who comes to the emergency department with a pain-related complaint should already have a Casper form filled out and placed on the chart. If they don't, you can ask the nurse or the registration clerks, and the registration clerks can make that happen. The nurse can help you find the right people if you need that. So you review the Casper note or Casper for the person, and then before that patient is given an opiate prescription or controlled prescription, we are obligated by this bill to counsel the patient on the addictive nature and ability to develop dependency from opiate pain pills. And then we can only write the prescription if the patient does not have an existing prescription for opiates filled recently that should be continuing, or there is some other reason why we would write them. So we have to review it, make sure it makes sense and is reasonable. We have to discuss with the patient the dangers of these medications, and then not only do we have to do that, but we have to document it. So I'm going to show you how to do a Casper note. Now, this Casper note does not have to be filled out. You can just addend this, what I'm going to show you, to the bottom of the patient's other note. So here's the Casper report. And so if you forgot to put it in, you can always put it in as an accessory note. Now what I'm going to put is .KAS, which is an acronym. It's an acronym that expands to review the Casper report, discuss with the patient the risks, benefits, treating with narcotics, and they understand the risks and proceed to treatment, including narcotics, be given detailed instructions on how to take it and watch for any complications. Now that is for a patient who determined can be given opiate pain medication. If you have a patient who the Casper report cannot be acquired because their website is down or their computer is down, then there is another thing that you can put another acronym expansion. It's .UAKAS. And this says basically I queried the Casper database and it wasn't available. Now this doesn't have to be placed on the Casper note. It can be placed just in the end or the ED course portion of your note otherwise. Now, in order to get an acronym expansion, you click here, and if you want to get those KAS and .KAS from me, you can click in to go to acronym expansion, import from other user. Now, my name won't be up here because I can't import from myself, but you can go in under my name on import from other user, and you can import the following from me: the .KAS, the .UAKAS, because that's going to be filled out. Everybody who gets a pain pill prescription, which is a substantial portion of trauma patients. And then some of the residents here have actually filled these out. I've taken these from the residents, which are physical exam, full for child, infant, trauma. Basically, you're welcome to get those as well. Those are acronym expansions that I'll show you how you can use those in a minute as well. Now, as far as documenting your note, I'm not the best at documenting, as you might imagine. The residents do the bulk of the documenting, and I lost that note. Just one second. The residents do most of the documenting, so they know better than I do, and so they can help you with this. If you want to do a note, we already have notes for trauma and general notes. If you do the general note, it already has the note broken into sections. If you do the general note with the asterisk, it's just a blank note, and then you would want to type it out just like you would any other any full patient encounter. Now, there are prefab notes depending on the patient's chief complaint. Some people like to use these notes. For example, this one that says PE full. Some people come in, some of the residents come in and and it already fills in a physical exam. Now, obviously, that physical exam is not something you want to take for granted, because a lot of it just comes in with normals, and so you have to be careful with that. But everyone has their own systems on how to fill out a note. I would get in there the first day, ask one of the upper level residents how to show you best how to document, and the documentation can be done from there. What is important is that a full note has to be filled out. You have to do a full review of systems, and you have to do at least 8 system physical examination to make sure we maximize our documentation and billing. A very important part of any note is an ED course. So after you do your HPI and your physical examination, you want to do an ED course that describes how the patient responded to treatment, the events that occurred during their time in the department, and also their testing. You would also want to make sure you put in a diagnosis for every patient that we take care of in the emergency department, and that's very important. Commonly, people will leave diagnoses, but you'll want to make a clear listing of your diagnoses. If you don't have a specific diagnosis, then you would want to at least put a symptom diagnosis. For example, if you had somebody excluded for appendicitis and you weren't sure what the cause of their abdominal pain was, you might just put number 1, abdominal pain, as their diagnosis. And when you take people and check them out, it's very important to make sure and go back on your next shift that the patients you checked out had the notes completed by the person who took them in checkout, so that they are complete. I think that pretty much goes over most of the stuff. I apologize, this is tremendously long. I hope this does help you, worth the hour and 15 minutes that you spent listening to this. If you have any questions, just go to the ER residents or ER attendings or ER PAs, and they can really help you. The nurses can be very helpful as well, but obviously the providers understand where you're coming from and can help you with this kind of stuff. Most important thing to take from this is enjoy your month. Most of the people you're going to be working with in our department are good to hang out with, generally social people, and it's good to meet the people that you meet your other colleagues. You'll get an opportunity to meet a ton of people from other services on the month as well, because as one of my old mentors told me, that the ER is kind of like the food court at the mall. You see everyone, and you're exposed to a little bit of everything. And so establish some relationships with people, get to know some of your colleagues, take care of patients you wouldn't usually take care of, ask questions, have a good time, and I hope you have a great experience. If you have any questions, obviously let me know, and I'll do my best to help you. I appreciate your time and looking at this horrendously long orientation video. Thanks.